thoracic surgery surface. And he will be talking about the options of open and endovascular procedure for the second stage after the frozen elephant trunk. Thank you.
Thank you, Jackie, for your introduction, and also want to thank Dr. Vera Wong for your kind invitation. I think we have heard a lot about total art frozen elephant trunk these 2 days, and I'm going to talk and more focus on the second stage. I think one important concept is after total art frozen elephant trunk, we try to minimize the number of times that we need to re-enter to the thorax. For example, if we just do an ascending replacement, then in a good 1/3 of our patient, we might need to re-enter, do the arch, and subsequently descending, so and so. So basically, these will not, the total art frozen elephant trunk is not going to stop us from doing a downstream procedure. Now, basically, the indication in our center is more or less compliant with the EX vascular domain indication. For type aortic dissection with small true lumen distal malperfusion is the indication that we do total art frozen elephant trunk. And in patient with previous type A dissection and then with residual arch and descending problem, we'll do it. And also for type B complicated type B dissection without good landing zone is also indicated. And multiple segment aortic pathology, in order to reduce number of re-intervention, we also do this. So we have previously published our operative video in CTS-NET in 2014. The first case was done in August 2014. And the video is available there. And from August 2014 to January 2019, we have prospectively collected all the data related to the hybrid thorax procedure. We have done now at the moment 37, but the data analysis was done when the numbers are 35. In general, the patient is of age around 60-year-old and predominantly male. And in our series, we have done 46% of all our cases of total frozen elephant trunk in acute type aortic dissection. And around 8.5% are with previous ascending aortic replacement. The operative time is variable because we have also doing a combined procedure as well. And basically, we would do, as long as the indication of I just mentioned, we would proceed with the total art frozen elephant trunk. The circulatory rest time is slightly longer because after a continuous suture over the distal anastomosis, we also use circumferential pledget felt reinforcement. That would take a longer time for the circulatory rest. And but the advantage of that is to make sure there is no bleeding afterwards. So you can see the PEG cell transfusion in general is actually less. It's around 4 units of PEG cell transfusion. In some cases, we actually don't need any red cell transfusion and don't need any blood product as well. In our series, we have 40% of our cases done in emergency setting, and there's a good around 25 to 30% concomitant procedure, including ventral and a CABG as well as an aortic valve replacement. One with ECMO is the case with coronary involvement that Malik just mentioned. Deadly combination. We did also CABG as well as put the patient on ECMO, and that patient survived. So the overall 3 days mortality, 30 days mortality is 8.6%, with aortic-related mortality 2.8%. The average intensive care stay is around 4 days. The inpatient stay around is skewed because one patient requires relatively long hospital stay. Resonotomy for hemostasis is 5.6%. We have stroke 8.6%, but the permanent spinal cord ischemia is 2.8%. And vocal cord paralysis, in our case, series is 8.5%. We try to either do a SOM2 anastomosis, or in case we want to perform a distal anastomosis, we stay within the aortic wall. So we dissect inside during the circulatory rest rather than dissect the outside of the aneurysm. So one thing I want to show is this is the Kaplan-Meier curve that plotted for all our survival case. Basically, you can see after the initial stage of mortality, we have a reasonably good midterm survival. The three mortality, one is aortic related.